Over to you, Dr. Prashant.
Okay, I'm starting. Good evening, doctors. Welcome to this webinar on role of oseltamivir in flu management. This webinar is brought to you by Heathrow Healthcare, an innovative pharmaceutical company. Heathrow Healthcare, the journey began in 1993. We have 30 years of excellence and 36 state-of-art manufacturing facilities, 300 plus products in portfolio and presence in 126 plus countries. Heathrow Healthcare has 21,000 employees globally and is the largest closely held pharmaceutical company in India. It's amongst the largest manufacturers of ARV, APIs, and FDFs in the world, and as Asia's largest API manufacturing facility at SEZ Complex, Visakhapatnam, Andhra Pradesh. Heathrow Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties, pioneering in quality and innovation, and has the distinction of bringing 4 biosimilar products to market within 5 years of initiation. They are darbepoetin alpha, rituximab, bevacizumab, and adalimumab. During COVID-19 pandemic era, Heathrow Healthcare, the pioneers in antivirals, offered oseltamivir, favipiravir, and remdesivir to the patients, because of which in August 2020, Heathrow Healthcare received an award of pharma excellence for COVID drugs. Today's webinar role of oseltamivir in flu management. We have Dr. Pallab Chatterjee sir as moderator and Dr. Subhashish Roy as speaker. Welcome Dr. Pallab, welcome Dr. Subhashish. Dr.
Thank you.
Pallab Chatterjee is MBBS DCH MD Pediatrics, DNB Pediatrics and FIP. Sir is Diploma in Pediatric Sleep Medicine from Colorado University, European Diplomat of Pediatric Respiratory Medicine, Chairperson Computer and Medical Informatics Chapter of IIP 2122, Secretary of West Bengal Academy of Pediatrics 2018-19, Member of Advisory Committee of Vaccination and Immunization Practice of IIP 2018-19, Member of Executive Committee of IIP 2020, Scientific Chairman of West Bengal Chapter of Pediatric Pulmonology and one of the founder members of National Respiratory Chapter of
Very
Pediatric
valuable.
Pulmonology. Sir has authored several chapters in various textbooks like PG Textbook of Pediatrics, UG Textbook of Pediatrics, IIP Textbook of Pediatrics, IIP Textbook of Tropical Pediatrics, IIP NRC Textbook of Pediatric Pulmonology, IIP Standard Treatment Guideline, IIP Guidebook on Immunization 2018-2019, etc. Once again, a warm welcome, Dr. Pallab.
Good evening.
Ashish Roy, sir. Good evening. Is MD DCH, sir, is consultant pediatrician, Manipal Hospital, Calcutta, with a vast experience of 35 years. Organizing Secretary, Respicon 2023, Honorary Secretary, West Bengal Chapter of Pediatric Pulmonology 2018-2024, 2018 to 2024, Joint Secretary, West Bengal Academy of Pediatrics 2022, Joint Organizing Secretary, Respicon 2007, Joint National Convener, ATM Revision Committee 2021, National Trainer of ATM, RTI, GM, UID under 5 Vs, ARCTM modules, contributor of ATM to 2009, 11, 20, and 21, and care module, contributor of pneumonia in children module, pulmonary imaging module by National Respiratory Chapter. Once again, a warm welcome, Dr. Subhashis. And sir, Dr. Pallab, over to you now.
Good evening, and
Good evening, sir.
uh, I think we are audible and visible.
Yes, sir, very
So
clear.
I'll yeah. So we will start our slide sharing,
Yes, sir.
and basically today we intend to discuss about the empiric use of oseltamivir in flu management. And I am Dr. Pallab Chatterjee, and you all know Dr. Subhashish Roy, and we'll be discussing about this oseltamivir, how we can use it empirically in the management of flu. So, today we'll be discussing healthcare challenges in monsoon and their diagnosis, influenza and its complications, clinical evidences of oseltamivir, and the guideline recommendation for empiric use of oseltamivir. So, to start off, we will start with a case. This is a 4-month-old male child who presented with the typical findings that we see at this time of the year: cold cough for 4 days, high grade fever, there was difficulty in breathing, and there was a history of severe cold and cough in the attendant. The child was sick looking, clear nasal discharge was there was harsh cough, throat was congested, chest had the child had tachypnea, there were recessions, conducted sounds, fine rales and bronchi, and other systems were normal. So, Dr. Roy, given this scenario and the current findings that we have in this child, what do you think that the diagnosis is, and should we go for any investigations in this child?
Sorry. So
Mm,
this is a sick-looking child with a history of fever, with a harsh cough, with hepatomegaly. There is a tachypnea, recessions, and rales and rhonchi, with a history of contact with a person who is suffering from a similar disease. So it is in the line that this child is suffering from a viral infection. This is number one. Number two, a child who is of 4 months having tachypnea, rhonchi, rales, and with a most likely the hepatomegaly is due to air trapping. The liver is pushed down. So most likely we are dealing with a child who is suffering from bronchiolitis. Now, investigation is necessary only when the child is extremely sick. No routine investigation is necessary right at this moment, but it is necessary when the child is extremely sick, admitted in the hospital, or if you are thinking of a disease, of a viral infection where you have a medication which can shorten the duration of the suffering. So, right at this moment, I will not advise any investigation. I will observe the child, give symptomatic medication, and if the child is not improving or deteriorating, then I will go for investigation like chest X-ray or PCR from the nasal aspirates.
okay, so yes, so this we thought actually of bronchiolitis only, and management was given only symptomatic oxygen. And what happened was, any idea about grading of this bronchiolitis?
Now, this is grading is very simple. All these points are difficult to memorize, but by and large, broadly, we should remember that in mild, the child can take feed or sucking well, the saturation is well maintained, the child can sleep, and the child is not very irritable. Now, in moderate bronchiolitis, the saturation is less, but it is correctable with oxygen. Appear to short of breath during feeding, but can continue feeding, and the child can sleep even if you prop up the child or put some nasal drop in the nose, clean the air passage, the child can sleep with difficulty. But in severe, the child will be unable to or take the feed or the fluid. The child will have a hypoxia, and it is not so easily correctable with with oxygen. And the distress is definitely marked. There will be severe tachypnea, there will be severe retraction, and the child is extremely irritable. And it is many of the times the pediatrician gives sedatives in these children to sedate the child, which is absolutely counterproductive. The child is irritable because of hypoxia. If you don't give
Exactly,
oxygen, the child will not be comfortable.
exactly, exactly. And nowadays we are using a lot of high flow nasal oxygen also for
Yes.
these children, and it is giving very good results. Yes, so basically, we see these upper respiratory infections that are quite common in children, and sometimes the cough can last for around 2 to 3 weeks even. And usually, initial part the fever comes, and then the fever goes on, and then the child has this prolonged cough. And the typical history that mothers say is they had fever, fever is now fine, but the cough is not going. So that is very common, and we have to tell them that around 6 to 8 episodes of cough and cold in a year will not need any investigations. That is perfectly normal for a child. Now, we did admit this child because this child was sick, and we did some investigations, and this was the X-ray of this child. So, Dr. Roy, you want to comment anything on the
Uh,
X-ray?
this X-ray is not so bad considering the clinical features of the child because there is a large thymus. Otherwise, the diaphragms are not that flattened, and the ribs are not also horizontal. There are here and there few interstitial shadows, few alveolar shadows, but very few. So by and large, this X-ray is not so bad, but the clinical features are rather worse if you compare with the X-ray with the clinical features.
Correct. So, we didn't do anything at this present moment. We continued with the symptomatic management, but the child was not improving. So, we repeated the X-rays, and gradually we saw that there was a worsening.
Yeah.
So, yes, Dr. Roy.
So this gradually, if you see the first day, the second day, gradually there is an air trapping, and on the right side, if you cannot identify any bronchovascular markings, and on the fourth day and the last day, there are upper lobe patchy consolidations. There are some alveolar shadows, some interstitial shadows also there. The diaphragms are flattened and the reefs are horizontal. So there is a huge air trapping. There are interstitial shadows as well as some alveolar opacities are there, especially in the right upper lobe.
Right. So we did a PCR from the nasopharyngeal swab, and we did get influenza virus, influenza A RNA detected. So, investigations, Dr. Roy, do you want to do
Yeah,
investigations in these? When do you want to do a PCR actually?
when the child is not improving, basically, I have given supportive management. I have thought ki it is a child with a bronchiolitis, but the hypoxia is not getting corrected, or the child is gradually having more and more distress. The child is desaturating. Then definitely I will try to identify what virus is in the background. And influenza is one of the very few viruses where we have some medication, and starting the medication in right time will give a magic result, absolutely. So when the child is not improving with all my medications and empirically what I have tried, and the child is not improving, then definitely I will do RT-PCR.
Yes. And also, sometimes we do it when there is an epidemic of
Of course,
influenza
yes.
going on in their locality, and we
Or
want
in
to
the
rule out
family,
early.
there are few persons who are
Yes,
suffering from similar diseases.
yes, yes, yes. So this is the test that we usually do, the BioFire test, and we get a lot of viruses. And mainly, what we are interested in are the bad viruses, either which have some medication for them, or you want to prognosticate, like adeno, like metapneumo, like RSV, or maybe influenza, which has a good management. And we
Right.
did get these reports on the even on the newspapers that be on guard for swine flu virus. So in the monsoon we have these various illnesses like the influenza like illness, ILIs, the H1N1 or any other flu, the severe acute respiratory illness, and the COVID. And what we see is the number of year wise, the number of cases and deaths are increasing in our country also. So, if we look at the overview of influenza in our country, definitely the number of cases are increasing because the more and more probably we are testing for them. Previously, we never used to test and we did not have a data. Now we are testing, we do have data, and we which says that not only the cases but also the deaths are increasing alarmingly in our country. Now, Shubhashish Dar, can you like elaborate on the various types of influenza viruses that we have at the present moment?
Yeah, influenza A, B, C, of which most important are A and B. C also causes some mild illnesses, but usually does not produce a very serious epidemic. Now, A and B, there are few classifications of A and B. Basically, there are two classification variants, one based on the neuraminidase and the other one is hemagglutinin. These are the two proteins which are present in influenza A, and we are more interested with H1N1, which is a swine flu, and H3N2. So far as the influenza A is concerned, influenza B, there are two lineage. One is Victoria and the other is Yamagata. But Yamagata is not last few years. Very few
Right from
cases
COVID,
are
from 2020, there's been no reported case of
no
Yama.
reported case of Yamagata. So most of the influenza vaccines are becoming trivalent instead of quadrivalent. And currently circulating human subtype A are H1N1 and H3N2. These are the influenza viruses. Influenza C do happen in human, but they are very mild, and that's why we are not concerned with influenza C.
Right. And what is we have to understand is it can transmit very, very far away. So even 6 feet away, the flu virus can transmit. And when somebody coughs, sneezes, talks, so this can spread, that can land on the mouth or noses of people who are close by, inhale into the lungs. And therefore, we always advise the kids who are affected to stay at home, not go to school. People who are affected should not go near kids to transmit the virus. So they should be away. Particularly, they should avoid going close to their grandparents, because very commonly these kids, they have this infection. They go and meet their grandparents and transmit the infection, and they can become very, very sick. And it's also very important to wash their hands often and not to cough and sneeze on their hands, but on the sleeve. And the problem is that they start infecting around 1 day prior to the symptoms that they develop, and up to 5 to 7 days after becoming sick. And I think we all see this in our clinics, no, that mothers and parents come and say that, yes, I also have a cold, but the child got infected before I got. So basically, what happens is they start spreading the disease much before the child gets symptomatic, and these people become symptomatic maybe 1 or 2 days later. So that is very important to understand, that they start spreading the disease, and the children can go on spreading the disease for a long, long time. So, Shubhashis, when we see these patients of influenza-like illnesses or influenza, swine flu, H1N1, clinically it is very difficult to differentiate between these. So, is there any specific marker that you look at if you want to really differentiate between these infections?
Basically, one thing is very characteristic, that is your loss of smell. If you have a loss of smell, then definitely you are dealing with a COVID. In fact, couple of weeks back, I suffered from COVID because there
Oh,
was a complete loss of smell. So
mm-hmm.
far as the transmissibility, that in the last slide that you were talking about, transmissibility of influenza virus is even can be even higher than that of COVID. So it is
Yes,
very easily spreadable. And the shedding of the virus in influenza B is slightly different from influenza A. Influenza B, the shedding of the virus starts 2 days prior to the onset of symptoms. And then there is a gap of 1 day, and again 2 days post the symptom appears. Influenza A, basically the virus transmission happens from the day of symptom to next 48 to 72 hours, but it can be as long as 7 days. And rest of all the things are more or less similar. Only thing is that in the influenza like illness, it is slightly milder disease. So breathlessness or hypoxia is slightly less if you compare with SARI or H1N1. Now, COVID, the virulence is much less, but
yes,
and I have checked my when I suffered a couple of weeks back when I suffered from COVID, because I didn't taste, but I was there was a complete loss of smell. I didn't have any nasal obstruction. There was some runny nose. Now the COVID virus, there is a runny nose which is very uncharacteristic of the earlier COVID. In the
yes,
earlier COVID, we didn't see so much of runny nose or coryza, but the cough was more predominant. Now the virulence of COVID-19 is less. Now they are presenting with just like another flu virus. So it is very difficult to differentiate between these two until and unless you get the loss of smell.
yes. And emergency warning signs that we have to always remember, that in children, if there is very fast breathing, the child is irritable, there is involvement of the mentation, the child is not eating well, not drinking, not waking up, does not want to interact, there is cyanosis. So all these things are there which we have to be very careful about. And again, in adults, the same thing. Basically, there is difficulty in breathing, shortness of breath. The patient has got mental issues like, confused, dizziness, and severe persistent vomiting. So these are signs where we should immediately seek medical advice. Complications, as has already been mentioned, we all know that these infections can lead to worsening of existing diseases. They can cause bronchitis, ear infections, pneumonia, ultimately ARDS, and also death. So there can be various complications that is possible with flu. Now, the main part about flu, treatment of influenza, other than the usual ones that we do, the symptomatic treatment like bed rest and increased fluid consumption, analgesics, antipyretics, and NSAIDs might be given if there is severe myalgia. Cough suppressants, if required, if there's a hacking, distressing cough, then cough suppressants can be given, and they usually recover, but malaise can persist for several weeks, and many patients may need hospitalization and other supportive measures. Now, Shubhashis, what about these antiviral drugs that are there for influenza?
The antiviral drugs are basically two types. One is neuraminidase inhibitor, that is the most commonly that we use. It is oseltamivir. Zanamivir is basically, from so far as my knowledge goes, is inhalation. It is not oral drug and cannot be given below 7 years. They basically stop the replication and transmission of the virus, basically. So those viruses which are already in contact with the receptors, on them there is no action. But as that is why, as so the earlier you start using them, the symptoms will subside earlier and faster, and the child will get relief much earlier. So mechanism of action is that neuraminidase cleaves the receptor from where the virus particle will infect another cell. So neuraminidase cleaves the receptor. If you block the neuraminidase, it will not be able to cleave the receptor. So the virus particle will remain in the cell which is already infected. So it will not infect a new cell. So gradually the viral transmission will be less, symptoms will be less, and the child will recover faster. That is why the dictum is that earlier you start the therapy, better is the result always.
Yes,
So
so basically, so it halts the viral replication. That is very
yes,
important. It does not kill the virus, but it halts the replication of the virus.
right. And one point in the severity of the influenza that you have shown in adults, confusion is a very important symptom.
Yes, yes.
Confusion can be a feature of
Even in
even
children.
in
Yes.
children, but in children confusion comes later. But in adults,
Mm.
even the hypoxia, even the tachypnea is not that high. If the old person is hypoxic, then the person can be confused. And the second thing, in case of sepsis also, no other feature is there, but the elderly person is confusion, suffering from confusion, incoherent talk. That can be a feature of sepsis itself, without any fever also.
Absolutely. So this oseltamivir is available as Fluvir. It is approved in more than 100 countries, and all the major organizations, they approve the use of oseltamivir. As Dr. Shubhashish Roy said, Zanamivir was available for some few years, then it has died a natural death because you cannot use it in young kids, and it can worsen your asthma and all these. So, oseltamivir dosage, we all know this dosage that is there. Adults, it is 75 milligram capsule. We don't use it for chemoprophylaxis anymore. This
Right.
was there when we had this epidemic of swine flu that was going on. And in kids, the way it is 3 milligram per kg twice daily. It is available as a syrup form also, and it's available as capsules. And it's also you have the weight-based doses that is there. So now the issue is early usage. So various studies were done where oseltamivir had been used. This was, for example, a prospective study where data was taken on lower respiratory tract infections and antibiotic use in children ranging from 13 years to adults up to 97 years. So it's a huge range of age group and large number of subjects. and they were all enrolled in various placebo-controlled double-blind trials, and oseltamivir treatment was analyzed. What it showed was that it reduced the antibiotic usage by around one-fourth. So it reduced the influenza-related lower respiratory tract infection cases and resulting in antibiotic therapy reduction, and it also reduced the hospitalization. So early usage of oseltamivir did help in reduction of many of these problems, and reduction in occurrence and severity of pneumonia due to early administration. So this was what it showed, that the medium time from symptom onset to oseltamivir administration was usually 5 days. So that is what usually happens, is that we do the tests and we decide that whether we should give or not give in patients who are not that sick. But patients who are very sick and get admitted in the hospital, we usually start off with oseltamivir, and if it comes negative, depending on the child, we sometimes stop or sometimes we continue. So in this study, the subjects were divided into various groups: less than 2 days, 3 to 7 days, 8 to 14 days, and more than 14 days, when the on oseltamivir was administered from the time of infection. Now, Shubhashis, can you detail this slide? This is a very important slide which shows that when to initiate the treatment of oseltamivir.
So both the probability of any severity of the pneumonia and probability of severe pneumonia increase gradually with the time from symptom onset to oseltamivir administration. There is a logic behind that. The earlier you start the oseltamivir, less number of virus will infect the cells, and as a result, influenza virus destroys the mucous membrane, the cells of the mucous membrane. So the number of cells that are destroyed or sloughed out will increase the chance of secondary bacterial infection. So earlier initiation of oseltamivir administration after symptom onset significantly reduced occurrence and severity of pneumonia, because we have seen it, the child improves magically as soon as you start the oseltamivir. And post influenza, there is a very high chance of staphylococcal infection. So if you start, then the number of cell death by the influenza will be less, and and the chance of secondary bacterial infection will be less. And as a result, the chance of secondary bacterial infection related pneumonia will be less, and antibiotic requirement will be less.
Right. So, but what this study has also shown, that if you start oseltamivir, if you do not get the window of opportunity to start oseltamivir early
Yes,
within the
yes,
first
definitely.
2 days, even if you start later, it did show considerable potential for reducing the infection. So that is also
Because the
important,
virus
that you
getting,
start early. But
yes.
if you miss, do not hesitate to start, because it you have missed out the first 48 hours. So that
In
is
fact, that
that.
matches with our clinical practice also.
Exactly, exactly.
Even if we start on fifth day or seventh day, we have earlier missed the diagnosis. Later on, with clustering of symptom, we are thinking, yes, it can be, and the child is not improving with the standard treatment. The child is having a very bad cough. It is almost fifth or sixth day of the disease. Even that time, if you start oseltamivir, the child will improve within no time.
Yes.
That is very important. Yes.
So, what do the guidelines say? WHO strongly recommends empiric treatment to start it as soon as possible. Lab confirmation always is not necessary to initiate, and sometimes, even if you have a negative test for H1N1, it does not exclude the diagnosis in all patients. So, early treatment is very important, particularly in high risk individuals who have been exposed to this thing. Sorry for the and an early empiric supportive therapy. We should give empiric antimicrobials to treat all. Sorry, give me a second, please. So, Shubhashis, what about this early empiric supportive therapy for pathogens causing all SARIs, and when do you start treatment for influenza?
So it is not that every child who is having a symptom of viral infection, runny nose and cough and fever, you start giving oseltamivir. It is not that. But if there are few family members who are involved, who are suffering from the similar kind of disease, this is number one. The child is having a conjunctivitis with diarrhea, with a very severe hacking cough, and the season is corroborative of the influenza transmission, then I can start empirically oseltamivir, but what with a caution that it does not give a permission to all the clinician to start oseltamivir in every viral disease. No, if there is a clustering of cases, few family members are involved, there is a bad sore throat, there is a conjunctivitis, there is a high temperature, the child is very sick, then empirically you can start.
Correct, correct. And so we have to, and particularly also if there is a local transmission and all that.
Yes.
So, the recommendation is, according to the American Journal of Respiratory and Critical Care Medicine, that to start anti-influenza treatment such as oseltamivir in patients who test positive. Oseltamivir is associated with reduced risk of death in patients who have been hospitalized with community-acquired pneumonias who test positive. And treatment, as we already have discussed, that it is best to start within the first 48 hours. But there can be benefits even if it started late, so we never hold back the treatment once diagnosed. Now, Shubhasista, this child, 2 year old, came with fever for 3 days with chills, dry cough. So this is a little bit older child. Again, sore throat, conjunctiva was red, there was body ache and vomiting, there was harsh vesicular breath sounds, tachypnea. The patient was started on comoxiclav and some cough syrups. The situation did not improve. 2 days back, the father was admitted with high fever, fatigue, severe cough, and today the report of the father has come as influenza B. Now, what do we do?
Now, there is a very strong contact history with the child, that the father was suffering from influenza B, and the child is also having similar symptom with a fever, chill, body ache, conjunctiva rate, sore throat, tachypnea, harsh vesicular breath sound. Apart from the symptomatic management like increased fluid, paracetamols, and if necessary, bronchodilators if there is any rhonchi, I will not hesitate to start oseltamivir right away. A suspected case is someone who is having an acute febrile illness but not with a contact history, and within 7 days of travel to the community where there are one or more confirmed influenza cases, but you have not got any positive result from the PCR. So we have suspicion. You have the setting of influenza, but the virus has not been demonstrated. That is a suspected. Probable means you have demonstrated the virus, but you have not identified whether it is H1N1 or H3N2. So subtyping has not been done. So it's positive for influenza, but unsubtypable. And it is positive for influenza by an influenza rapid test or influenza immunofluorescence assay. But currently, we are more interested in PCR so that we can get whether it is we can get rapid result whether it is H1N1 or other subtyping is
Yes, so it can be
easily.
subtype. Mm.
It can be subtyped easily. And in individual with clinically compatible illness who died of an unexplained acute respiratory illness who is considered to be epidemiologically linked to a probable or confirmed case. Yes, that is another clause so far as the probable case is concerned. And confirmed case is confirmed case setting. The clinical features are the same, and the real-time PCR or viral culture fourfold increase in influenza virus specific neutralizing antibody. If either of them are positive, then definitely it is a confirmed case.
So nowadays we do only PCR because it's easily
Only
available,
PCR, yes.
and
Viral
the
culture is
price
not
has
so
also
easy,
come
na?
down. Yes, yes, yes. These are all theoretical basically.
Theoretical things, yes.
So now this thing that we wanted to discuss, the category Cat A, Cat B, Cat C. So can you elaborate on these
Yeah,
categories?
cat A is a very mild disease. The child is having fever The child is having slight amount of cough or slight amount of sore throat, and the child is comfortable with paracetamol, increased fluid, or the cough medication, whatever you think suitable for this child. And with ORS, the diarrhea and vomiting can be controlled. So this child who is easily manageable, not having severe symptom, you do not rush to start the oseltamivir. Why this recommendation? Because in that case, every viral fever will fit in this category. Even in bronchiolitis, there will be a mild fever, cough, plus or minus sore throat, because very young children will not be able to complain of sore throat. There can be diarrhea in any viral illness. More so in adenovirus, there can be diarrhea also. So if the things are very mild, don't start oseltamivir and should be treated for the symptoms. Now, if the child is having category A plus high grade fever, the child is extremely sick, severe sore throat, and which is very disturbing for the child as well as for the parents, because the child is not willing to gulp a single spoon of water or not taking any food. So that's a very difficult situation for the parents itself. So in these children, or there are risk factors like a person who is having diabetes, or a child who is having chronic lung disease, or the child is having nephrotic syndrome,
Cyanotic heart disease.
cyanotic heart disease, yes, cyanotic heart disease, or having immunosuppressive therapy, there you don't wait. Start the oseltamivir. And category C is the child who requires admission. The child is unable to feed, unable to eat, unable to take fluid. The child is having breathlessness, severe cough, drowsy, falling blood pressure, hypoxic, and such a severe cough that there is a sputum mixed with blood, and that can come from severe cough, or it can be because of destruction of the mucous membrane of the respiratory tract. So in both the cases, their sputum can be mixed with blood and cyanosis if the hypoxia is very severe. So in these children, needless to say, you require oseltamivir. You have to admit, give all supportive therapy. You may require to start the antibiotic as well as oseltamivir.
Yes. So very sick patients, or when you have the child who's becoming gradually sick, we start oseltamivir. A patient who's not that sick, we would like to wait and see what how this symptoms continue, and continue with the symptomatic management. So basically, we all discussed this, that patients who are hospitalized with flu, patients who are very sick but did not be hospitalized, or patients who are at risk, having some problems, some risk factors, these are the patients, like patients with asthma, chronic lung disease, chronic heart disease, diabetes, or pregnant women. So these are the patients who should be started on oseltamivir at the earliest. So with this, we come to our third case. So this is another a case who becomes very sick. So this is a 2.5-year-old child with fever, with chills, body ache for 2 days, and then started having severe cough and sore throat, breathlessness, not taking anything orally, admitted in hospital. Other family members, there is no history of contact. So this child was sick, so was admitted in the hospital, was started on IV fluids, oxygen, levosalbutamol and ipratropium nebulization, and co-amoxiclav was started, and there was no improvement. And this was the X-ray of this child. So Shubhashis, can you explain this?
Yeah, this child is having a severe ear trapping. You can see the diaphragm is absolutely flattened. There are interstitial shadow and some ground glassing in the left upper lobe, and the ribs are horizontal. So air trapping, viral setting is there. So it is a viral infection most likely, because interstitial shadows are more, and on the right heart border is almost obscured. So this X-ray fits in with any viral disease where there is an air trapping.
Yes, and the PCR was done and it showed influenza B. Actually, we find influenza B, those infected with influenza B becoming more sick compared
Right.
to influenza A.
Yes.
They may not spread that much like influenza A, but then it's very localized spread of influenza B. It doesn't have this widespread pandemic sort of spread, but they become quite sick. So oseltamivir was added, and fever and cough was much less the next day, so antibiotics were withdrawn. 2 days later, high fever with chills again, tachypnea, bronchial breath sound in the infraclavicular region, and these were the X-rays. So
So
Shubhasish, that's yeah.
this child is having in the left hand side X-ray there is a right upper lobe consolidation as well as some amount of middle lobe and right lower lobe also. You can see the right lower lobe also consolidated, and there can be some amount of fluid also because the right prostrophrenic angle is obliterated. On the X-ray right-hand side, there are areas of breakdown, and as a result, I cannot say the child is improving. Rather, it is probably the child is having necrotizing pneumonia because there are many breakdown areas in the right upper lobe. And the child with ceftriaxone started 2 days later, the fever more. The child has become more toxic. The total count is very high. CRP is 220. Definitely, we should think about necrotizing pneumonia. So clindamycin added, the patient improved, discharged after 4 weeks. One point is that, and in the if you see the right hand side X-ray, the right upper lobe and the right lower lobe both are involved. So it can happen with Streptococcus pneumoniae, but it is more common multilobular involvement. And in the right upper lobe, you can see very well the air bronchogram also. Now, different lobes are involved, almost the three lobes are involved, so most likely we are dealing with case of staphylococcus. And MRSA post influenza is a very serious problem. So here you should add something, add vanco with clindamycin or ceftaroline. Only vanco will not give adequate result because lot of cell death happens and the penetration of the virus is inside the lung is very fast, with some toxin liberation also can be there. So clindamycin is also very good in these cases. And of course
Right,
with oseltamivir.
right. Suddenly, I don't know why we are seeing a huge outbreak of streptococcal pneumonia uh, in our locality now. And they are all like, they have this multilobar involvement. They have severe empyemas, necrotizing, abscess formation. Like in 2 days, the CT scan was done when a patient had been referred to us, and the OT on table was found to have a huge abscess which was not visible on the CT scan just 2 days prior.
Oh,
So massive pneumonias we are seeing now with empyemas.
so is the child vaccinated?
Yes, 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 yes. From a very good family, very well off, all vaccines taken.
So most likely these are PVL, most likely
No,
because
no, 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 no. The it came as Streptococcus pneumoniae, single organism on the PCR. So we sent the PCR, and only single organism was Streptococcus pneumoniae. And all these patients, we're not seeing a lot of staph. And
hmm,
we actually started all these Vanco, Clinda, and everything, but then we are seeing very little staph. And usually PCR picks up 3, 4 organisms. Here, these patients, no, we are sending this PCRs and it is picking up only strep pneumonia. Very strange. Very, very strange. So, means uh, only growth of.
they are not immunocompromised.
They're not immunocompromised. They are quite well grown and otherwise fine.
So it is a community acquired pneumonia basically. In fact,
Yes.
these pictures we have seen 2 years back also. A lot of empyema cases from Streptococcus pneumoniae happened
Yes.
in 2023 also. I have not seen this year.
Yes, that's what. Okay, so that's beside the point. So what we wanted to say is the proper diagnosis can and early treatment can prevent flu complications. Empiric use of oseltamivir reduces lower respiratory tract complications, hospitalization, antibiotic use, and all the important societies all over the world, the Ministry of Health and Family Welfare, the ATS, the WHO, they all recommend empiric use of oseltamivir at the earliest. So thank you very much for your patience, and we open the house for discussion.
Thank you so much, sir. It's a very interesting case that you are discussing Streptococcus pneumoniae. I can tell you, here in Mumbai, there appears to be a sudden rise in influenza cases with this weather
Okay,
Okay.
changing. I mean,
okay,
I do
okay.
not know, maybe it's transient or what, we do not know. Suddenly, we are seeing this rise.
Mm-hmm.
Okay.
We are
Yeah,
we are yet to see it. We are yet to see.
yeah.
Yeah.
It
Yes.
may be transient, maybe, we don't know, but then we
Mm-hmm.
did see.
Virus induced. wheeze are increasing for last couple of weeks because
Oh,
maybe,
Yes.
yes.
but not exactly influenza I have
Yeah,
seen.
I mean, influenza is a general statement I made. It could be
The
Yeah,
flu-like
yeah, yeah.
illness.
Viral.
yeah,
Flu-like illness is there.
flu-like illness,
Definitely. ILA
flu-like
is
illness.
there.
And another
Yes.
interesting is sir suffered from COVID, which you almost thought is gone.
Uh,
Another interesting,
yeah,
yeah,
yeah.
yeah.
I suffered from COVID. There is no iota of doubt because there was no nasal congestion, complete loss of smell.
I mean, you say there is cannot be any doubt.
And the thing is that even after 3 weeks, I have not recovered fully.
Yeah, I mean, it
Some
has a
amount.
long-term effect. It has a long time. Anyway,
Yes.
take care, sir.
Thank
Thanks,
you so
Dr.
much.
Subhashis. Thanks, Dr.
Thank you.
Pallab. Thanks, Sai Srikhar. Thanks, Samruddhi. It was a pleasure always, listening to these interesting cases.
Thank
And
you so much.
signing, you can sign off, sir. Wish you a
Thank
very
you.
happy 2026 and hope to see you soon. Thank
Yeah,
you so much.
Merry Christmas also from our
Yes,
side.
Merry
sir.
Thank
Yes,
Christmas.
you.
sir.
Happy New
Yes, sir.
Year. Thank
Yes,
you
sir.
very much. Thank
Thank
you.
Thank
you.
you.
Thank
Thank you. You can sign off, sir. Thanks,
thank
Sai
you.
Srikhar. Thanks, Samruddhi. Thanks.
Thank you, doctor. Good night.
Thank